Okay, so question here.
Thank you. I know there is a plan for a dedicated unit for adult hearts at Auckland Hospital. How far on is that plan?
You mean in terms of facilities on the wards?
Beds for dedicated beds with dedicated staff.
Not very is the answer to that, Stuart. It would be nice. The hospital certainly seems to get ever fuller and fuller, unfortunately. But we're certainly, I'm keen to try to develop a couple of at least specified rooms anyway that we have available, and which are just more youth-friendly in particular. And Rob and I have talked a bit about that too, and you know, that's something, it was kind of on my radar, and then we didn't get funding and it sort of fell off a bit, but it sort of stimulated me a bit, the discussions that we've had at this meeting, so I'm hoping that we'll be able to move a bit on that in the near future. In terms of staff, we have increased our staffing numbers recently, particularly in terms of our senior nursing staffs and their specialist staff. And we have increased our psychology tenths, so we now have 0.6, or will very shortly have 0.6 of a psychologist who's purely there for the adult congenital team, which would be nice. And there are certainly plans afoot for that to increase, so we have agreed funding from the government, which will increase senior nursing staff further, it'll increase consultant medical staff, we'll have a middle grade fellowship role in the near future as well. So there's quite a, we're very pleased with that result, and that's there on paper and it's agreed to, so that will come in gradually over the next 5 years.
Can I just carry on from that, please? You're pleased and so forth with that, and it is good. Did the hospital, did you get a reason, sorry, did you get a reason why there's no funding to go forward in that way? Or is it just no money? Because these numbers are only going to increase of these people.
Money is... Karen's getting fit, which you might be fit already, I don't know. Fitter. Yeah, I mean, money is tight. And yeah, we've been really lucky with that staffing increase, those staffing increases, but that's kind of comes centrally from the government. Getting money directly from the hospital is very difficult. But, you know, I think in terms of just developing the actual environment on the ward, hopefully that's something that we can work together with Heart Kids, for example, and you know, I think we should be able to move on that.
Thanks. I think sort of one of the take-home messages from the liver and kidney stuff was that we don't really know at the moment what lessons to take away from that, or what information to take away from that. But what should we be monitoring for? Should we be monitoring our livers and kidneys on the basis of FibroScan each year or every couple of years? Should we be just getting blood tests and monitoring the ALTs and things? What's useful? Because I suppose my expectation, and my sense so far from tests that I've had personally is that people see some abnormalities in the liver and then they go away and do some research, and it turns out that they're abnormal but not abnormal for the Fontan population. So that's probably not a useful way to monitor things. So what should we be doing?
There's two sides to the two sides to the answers. One is practically speaking. Normally, in medicine, you should investigate if you can offer a solution. And yes, there's no clear solution now. So, is it because you don't have a solution? Should you not monitor? I'm not sure. Unless you build up the knowledge, we're not going to go anywhere. Can I ask any of you who has, in your kids or yourself, who had a urine test? I mean, it's easy to check, but urine dipstick. You put the dipstick in the urine. Who had a urine or sample of urine collected? Who didn't have, just to see if you were asleep? Yeah. So you see that costs close to nothing. It's completely stupid, but that tells you if you have protein in urine, and we find out that maybe a third of them, a third would be positive. Yes, we don't have an answer, but if you find that you have protein in urine, maybe you should check more closely. You should check blood test of the renal function more closely to monitor that over the years. I don't think that's a bad thing, at least to know where you are with a conventional investigation. So that's for the kidney. Next year, personally, I'm not a cardiologist, I'm a surgeon. I would do a dipstick, urine dipsticks to everybody. It costs nothing, takes 2 seconds. For the liver, I've become, against my will, kind of a Fontan expert, and then I receive a lot of papers to review. When you look at really, a lot of people talking about liver cirrhosis, you look at really the real cirrhosis on biopsy, it's kind of not, my feeling right now is that it's not so many of them. Everyone has fibrosis. But the way I see things about fibrosis is like, when you walk bare feet, you get thick soles in your feet, and it's the same. You put a lot of pressure in your veins, the liver has to, fight back or so, and so it gets fibrotic. I mean, that's the way, if I'm thinking not like a non-medical person, it makes sense to me. Will they all evolve to cirrhosis? Some of them do, but I think it's still a small proportion. That being said, you can look at some diseases. You look at diabetes, and your body may be aging more quickly if you have diabetes. So if you, like me, are 50, 60 years old, I'm 52, I'm checking, I'm checking a blood test, I'm checking my liver function test. So maybe when you have a Fontan and you are 30, well, maybe you should just check your liver enzymes, and that's the minimum. We're building a partnership grant. Partnership grant, we're trying to set up a follow-up care, and we agree on one thing. We should check something about the liver and kidney. Hopefully, in 2-3 months, we know better what to check. So I'd like to have Tim and Rachel opinion probably about kidneys
and... I mean, yeah, I think you're right. A urine dipstick is an easy thing to do, and I personally ask my patients to have a renal function blood test and liver function blood test done annually, because those are, I mean, obviously a blood test is somewhat unpleasant, but they're straightforward, they're cheap. That's one bottom line, I guess. And I think, we see a certain pattern of relatively mild abnormality of the liver function blood tests that we see very commonly in Fontan patients. But I think if I see somebody whose tests are more abnormal than most people's are, or alternatively, perhaps particularly if I see the test changing over time, then I think that's potentially important and that's potentially informative. In terms of scanning and imaging of the liver, I really think we don't know quite what to do, and my own practice is to do an ultrasound, and I haven't really been doing them for quite long enough that I have a an idea of how often we need to do them. I've heard people in the US say that they should be done every year, which seems a little over the top to me, but I'm probably going to do them every 3 or 4 years, I think. The reality is I don't know how much information we're actually going to get from liver ultrasound, and maybe in reality you actually need to be doing MRI or something, but that...
I mean, ultrasound is a good way to check you have fibrosis, but normally it's a good way to pick up nodules, and if you have nodules, then it may be a detection for cancer. So it's probably a good screening. It's like we don't know yet. I mean, if you're a woman and you're 40 years old, you have a mammogram. So if you have if you were 30 years old and you have a Fontan, probably reasonable to do a liver ultrasound to check. I mean, I think the yield.
And again, it's in sort of economic terms, which is important. An ultrasound is a relatively cheap thing to do, I guess.
I think, and you mentioned the FibroScan. I mean, hopefully the cross-sectional, the liver renal study is going to help us understand a little bit more about what's normal and what's not normal in Fontan patients. And the FibroScan, for example, is the values that are called normal on a FibroScan for a Fontan patient are completely different because your livers have higher venous pressure and that alters the numbers. So we don't understand just yet how to detect important fibrosis of the liver using a FibroScan, and even ultrasound's not great. But because, as Eve alluded to, there is this small concern in people with more advanced liver disease that they might develop nodules in the liver, you'll probably start to hear a little bit more about your cardiologist wanting to get a liver ultrasound every couple of years. But once the liver does look more fibrosed, we might even start recommending scanning every 6 months with some special blood tests in the people that we're super worried about. So I don't want you to think we're going to be sending you all off for 6 monthly scans. But at the moment, that's probably the best we've got. But we're hoping to understand this a little better with our research over the next couple of years.
Can I mention something as well? Is that unlike other studies, if you do studies on anything in research, the beauty of the research integrated in the registry is that we have 150 FibroScan now. So we're going to follow everybody, and so if something comes up in the next 5 or 10 years, we'll know that maybe the FibroScan of this value is, means something. There are things that we may not find out now that we may find out in 5 to 10 years. It's likely that we're going to repeat the FibroScan in 5 years, and we'll ask all of those who have participated to do it again, a few years later, because that may be more interesting. And it's the evolution for yourself doing. Can I ask, when I talk about liver, we had that conversation with Tim and Tom and Terry yesterday evening, and maybe I'll ask. David is still around. It seems to me that when I talk to 20 years old about alcohol, compared to the average 20 years old. They all want to have a feel, and try it. But the feeling I get, and I get a lot from these days from you talking to us and expressing your views. I have the feeling that when you have a Fontan circulation, it's not so exciting to drink. Like you're probably sicker than another one when you drink. Can those who are in that age generation or have experience, can you tell me your views? You've never drank, I know, but you know other people have.
He's saying how sick I get after I... What are you asking, sorry?
No, it's not so much how drunk it is, but I think when you get drunk, it's you're more sick, or I don't know. You have there's something you can take more time to recover, or no. Yes.
I don't think so. No.
Okay. Any opinion? So you agree with that, David?
Yeah, for sure.
Yeah.
I need to get that routine from you.
Sorry, there was more questions there.
Without you giving away too many secrets, Ed, are you able to tell us anything about this proposed new drug that you were talking about, like how it works, what you were saying was amazing?
I can give you zero information, but if you're clever, you'll quickly find out.
Is it Google?
Sorry?
Is it by Googling?
I won't say more. But it's coming. It should be coming January, February. You'll hear about it, and we'll, as soon as we can advertise it, we will advertise it.
Should we be doing the bone density testing as well as the liver and renal?
I think you raise a really important point. And I think something that's come out of all this research is, as your cardiologists, we need to also be your general physicians. And I know in my own experience as well, and we'll see it in our results, that a lot of you have a low in vitamin D, and a lot of you have other hormone abnormalities too that predisposes you to low bone density, or once you hit a certain range, osteoporosis. So I think routinely, not every year, but I think once somebody comes to me in the adult service, I'd get it at the beginning, and then depending on how abnormal it is, I might not repeat it for 10 years if it was completely normal. But also just reminding your doctors to check your vitamin D levels and make sure that you're not deficient, because I think that you guys are a little bit more predisposed to that for a whole array of reasons. So yeah, very. What do you think? I mean, I think checking vitamin D in a child, but
And why they're deficient?
I think there's probably a number of reasons. One is a lot of people don't get out and do a lot of exercise. I mean, as a population, we see it in all our congenital heart populations. They're not as active as perhaps we'd like them to be. But I think Fontan people may have altered absorption of fat-soluble vitamins. And I think because of the altered lymphatic flow in the gut, that probably affects absorption of vitamin D. But that's a theory that we need to... Sorry? No, well, you need to... There's different pathways. So, and the sun converts it in your body to be an active form.
So
Okay. So my son quite regularly gets pains in his legs, and it's normally associated with if he's been exercising. And I'm just wondering, is that to do with the Fontan being from here upwards, your blood's all moving around really well, but the legs don't get as much? Is that what it is?
So it was fascinating on the first education day in Melbourne, 2 years ago.
Yeah.
That came up, that a lot of the families, a lot of the kids were complaining about leg cramps, and I make the parallel.
Cramp.
Sorry?
It's not cramp, because I mean, if you've got cramp and you stand up and you walk around like this, your cramp goes away. If my son stands up and walks around, he's like in excruciating pain. Walking around doesn't help it. It's not cramp.
So
You need to I find you have to elevate the legs and give pain relief.
So what happened is that when you have a Fontan circulation, compared to somebody of the same size, there's less blood circulating in the body. And so what the body does is the same thing that when you have in heart failure. If you have a failing heart, you have an increased sympathetic nerve activity. So you have nerves that send information to constrict your arteries in the legs, and so that redistribute the blood circulation to the central organs, so your brain, your liver, and all that. And so there's actually, we know that there's less blood going to to the muscle legs, so it makes sense to have pain in the legs. We haven't investigated, but that's something that came up by talking to you. I think that it would be nice for Brian, if he's still yeah, Brian, do you want to say a word about that and what you do about it? And people do different things about it, and that's something that is on our to-do list. We have some more urgent matters, but it's on our to-do list to to check about that.
So, leg cramps were brought up, and I think we use the word cramps, even though when you stand up, they don't go away. And it was a common thing between a lot of people who have the Fontan circulation, and just kept being this reoccurring thing. I had them when I was about between 8 and 13, 14. And I only, after that point, I haven't had any since. So, I can...
But you exercised a lot as well at the same time, no?
Yes, but this was more of at night when I was lying in bed. The pains would start. Paracetamol would usually knock it out. My family just put it down to growing pains, but it seems to be this common thing that a lot of people grow out of eventually. And I know there's other people with Fontan circulations who have gone through the same thing.
Tim?
It could be growing pains, of course, as well, but they're common. But this doesn't sound quite like growing pains, so no, this doesn't sound like it, I agree.
Can I ask Catherine something? Because you're a paediatrician, yeah. So what's your approach with vitamin D
well, I mean, the cross-sectional study obviously is age 13 upwards, so we'll get a lot of information about what's going on with the younger Fontan population through the cross-sectional, and the ones that do have the bone densitometry. I mean, it's not part of the routine screen in paediatric practice for paediatric cardiology at the moment. But obviously, if we're finding that 13-year-olds have already got issues with the amount of bone density, then it may spark us to obviously look at younger age groups to see if if it is more widespread, and obviously from a younger age, so that we can hopefully do something about it. But it's not part of our routine screening at the moment.
It's interesting too, vitamin D in elderly populations has been shown, if deficiency is associated with muscle weakness and reduced muscle bulk. So that's something else that we're looking at, is whether that might be one of the reasons why Fontan people seem to have reduced muscle mass.
Just with resistance training, like as a woman of a certain age, they talk about doing resistance training for bone density.
Yeah, that's right.
Does that help?
Yes, so there's good evidence to suggest that resistance training, well, aerobic exercise as well, that weight bearing does improve bone density, yeah.
Is it no different than what, is that no different than what we were talking about earlier when you were saying about the teeth getting looked at a lot earlier in life? Why put everything else off until later? I mean, it just doesn't make any sense to me to go, oh, let's wait another 10 years.
No,
it's just
but I think first of all we need to identify what the problem is and if it exists, and if we're able to demonstrate that vitamin D deficiency is especially prevalent, then in the guidelines we'll be able to tell doctors, hey, 20% of Fontan kids. Oh, sorry, you probably don't need to hold them. But yeah, we know all this stuff's helping us to determine what we should be doing, and then we're going to be able to create a recommendation based on evidence of, because we don't want to be sending people off for tests if they don't need it. Yeah.
And also, it is X-ray exposure. So when you do bone densitometry, you are getting X-ray exposure. We know that these kids get a lot of X-ray exposure. So we have to justify what we're doing.
How much is their density much different than what a normal kid would be? And so forth, like, are we storm teacupping it? Like, are we just concentrating saying, oh, because they've had Fontans, they're doing this? Are we really looking at everyone?
Yeah, I mean, in general, we know that children are obviously within the normal population are getting bigger and not exercising as much. So you're right, it could be something that's actually reflective of the broader population, and we may be finding that within the normal population, we're getting people with lower bone density and lower muscle mass. Obviously, we can't kind of address that with our studies, but
there are well-validated normal scores, and so whenever you get a bone density, it's compared to people of the same sex and age, and we get a score to tell us how abnormal that person is compared to what we would expect in that population. And there's very well-validated data about that.
Sorry, can I just make a point on that? Just in terms of bone density and warfarin, we know that it can have an impact. And I think at our institute anyway, and maybe someone can correct me here, but we usually do recommend a DEXA at some stage if your child is taking warfarin, because, you know, we have this really crucial period of bone growth that happens at a young age, and that if we miss that then, intervention a bit later, you know, is probably not as useful. I don't know, someone else might be a bit more of an expert, but I think if you are concerned, it's probably worth bringing that up with your cardiologist and getting them a DEXA.
And what age is that?
I think around 10. If someone else can. Yeah. So probably from 10 to 16 maybe. Ask your healthcare provider.
So we just have one or two more questions.
Sorry, just from a personal perspective, so a lot of things that you talk about, vitamin D and bone density and well, growth hormones and kidney function failure and so on. We see a lot of doctors. Does that information all go to you? Or do we need to be proactive and get that information to you?
Karen, you want to answer that? So, it varies. So we extracted information from cardiologists. If you're seeing other doctors, it would be welcome if you copy that you ask them to copy that to the Fontan registry. If you see other doctors, if it's reported by the cardiologist, you should receive a copy of the other doctor seeing your kid. But if it's not reported in a cardiology letter, we miss it. And the cardiologist reporting varies. You have, like everything in life, you have good guys and bad guys and average guys, and there's a lot of people where we have to extract the information by force, but it's improving with time.
So is there a way, we know that the information, endocrinology and spinal surgeon and everyone sends all the information to the cardiologist, but yeah, does it stop there?
Usually, what do you think? Usually, you can ask Ingrid and Janina, but I think that the most relevant information, the big stuff, would be reported in Ingrid in the letters.
Those letters, sorry, but yeah, the cardiologist letters once a year, mostly.
I mean, I think it's always good to be sort of proactive about that. And if you are seeing a doctor and you want them to copy their letter to other people who are involved in your care or your child's care, just say to them, please could you copy that letter to Dr. So-and-so as well, and take charge. Mm.
Is there a question up the back?
Why do you ask the question of being on sildenafil?
My child's she's 5 now, she's been on it for nearly 3 years. And there is, when she was off it, there is some noticeable changes, like she has a wheeze and she quite often gets a wet chest sounding cough. And I just wondered, like, the long term, is there any research about her being on it for a long period of time? Is she always going to be on it, or?
So that.
Can I just butt in? That's clear.
Ed might need to understand that the first line for pulmonary hypertension in New Zealand is sildenafil as opposed to bosentan. I don't know if you know that.
No, I don't know, but it's Claire. You may be able to understand to answer that question better than me, because I know that from the registry data, it's very exceptional to be on sildenafil. So it's a very, very rare drug so far to be used. It may be a very good idea, but that hasn't been the practice so far.
I think it might be interesting to specifically ask, that question, and whether other centres, we do have a scattering of folk both at the Glen stage and at the Fontan stage, where we've had some worries about pulmonary pressure where we're using sildenafil, and obviously it is. There's not an enormous amount of data around on that, and I think it's a really good question, and obviously there's a broader issue, not just of sildenafil, but about any drugs for pulmonary hypertension, and that's something I think people have got in mind.
Okay, any more pressing questions before we... Michelle?
I think I'm just after a yes or no answer. This is for you, Chantal. You know how you're doing the aspirin and warfarin studies? Is there going to be a study for aspirin and warfarin patients?
Probably the short answer right now is no, because we really want to see the difference between the two drugs. Although we know that there is a subpopulation that have had both. But when I send out that bleeding questionnaire in a few weeks, we want to capture everybody. So if you haven't given us our email address, I know I said this earlier, please jump on the website and update it, because we want to get everyone's data that we can. So I know that there's a few of you out there that are actually on other anticoagulants that we probably haven't spoken about today, and we'd like to capture that as well. So, yeah, thanks.
We're going to wrap up soon, so I just want to insist on the fact that we get a lot from here, from meeting you and having these meetings. I hope that you get a feeling that you're not alone, that you're communicating and making links with other people. I think I've said that, but I just want you to understand that the future of those with the Fontan circulation is in your hands. And so, exactly as Rachel said it earlier, we want this to be an empowering moment. We want you to feel empowered, and you can change things. When you're alone, you're nothing. When you're a community, you have a voice and you can make things change. If you're not happy with things, you want to push the things in a certain direction, it's in your hands. Tim, you want to wrap up?
So next year, I understand the meeting is going to be in Brisbane. Have we got a date for that? No date as yet, but watch that space. So we're going to finish here. I want to thank, firstly, all of you guys for coming. I know there's people who've come from all around New Zealand, and there's people who've come over from Australia, and it's your attendance that makes this such a fantastic and successful event. I want to thank all the speakers who've shared their time with us on a Sunday and given us some fantastic presentations. Thanks to the University of Auckland staff who've helped us out over the day. I think the venue has been really excellent. It's worked really well. So I think that's us, really. We'll see you next year.
And can I just thank Eve and Karen for all their extremely hard work with all this. You just do an amazing, incredible, amazing job.